Hello, and welcome to the Clinical Dialogue Program, Current Evidence and Controversies in COVID-19, discussion on best practices amid changing evidence. I'm Paul Auerter, the Sherilyn and Ken Fisher Professor of Medicine, and also the Clinical Director here at the Division of Infectious Diseases at the Johns Hopkins University School of Medicine, and also the Editor-in-Chief of the Johns Hopkins Point of Care Information Technology Center's Guide, the Johns Hopkins ABX Guide. Joining me in this discussion are two expert clinicians, Dr. William Fisher and Dr. Ed Jasper. Dr. Fisher is an associate professor of medicine in the Division of Pulmonary and Critical Care Medicine at the University of North Carolina School of Medicine in Chapel Hill, North Carolina. Dr. Jasper is the medical director of emergency management and associate professor of emergency medicine at the Thomas Jefferson University in Philadelphia, Pennsylvania. Before getting into the heart of the matter, let's discuss a bit of the important terminology regarding this novel pandemic coronavirus. Billy, could you tell us some of the important terms that everyone needs to know?
Sure thing. So there's two important terms that everybody needs to know. The first one is SARS-CoV-2, and that stands for Severe Acute Respiratory Syndrome Coronavirus 2, and that's the name of the virus that causes the disease. Now, COVID-19 is the disease that's caused by the virus, and that stands for Coronavirus Disease 2019. Now, there's some important features about the naming of these two entities. The first is that the name of the virus comes from the fact that the virus that was isolated from this outbreak shares a genetic homology or genetic similarity with the initial SARS coronavirus, or SARS, and that's why it's called SARS-CoV-2. It's about 80 to 85% genetically identical. Because it's more than 10%, it's considered a different species, and so that's why it's denoted as SARS-CoV-2. Coronavirus 19, or COVID-19, was actually coined by the World Health Organization, and this was really in an effort to separate the disease from the geographic origin.
Billy, that was great. As the world has embraced some of the terms about this novel coronavirus, we remain in a global pandemic as determined by the World Health Organization. These are things that are always quickly moving, and of course, you should look at your local and state health departments as well as the Centers for Disease Control to know what's going on in your own communities. I think as we look at a lot of the patients, many of us have a sense for who's most at risk for suffering severe COVID-19 or at high risks for dying. And then, Billy, what kinds of patients are you seeing most? You're a critical care physician. You're seeing, unfortunately, some of the worst cases that end up in our intensive care units. Who are you most concerned about?
Now, the severity of COVID-19 really spans a spectrum from asymptomatic to critical illness. And a lot of our understanding, while evolving, comes from large studies done by both the Chinese and the US CDC. The Chinese CDC initially reported on about 44,000 individuals who were confirmed to have COVID-19. They found that approximately 81% of individuals experienced mild or self-limiting illness, whereas 14% experienced severe disease characterized by elevated respiratory rate, oxygen desaturation, and really requirement for hospitalization. And about 5% suffered critical illness. This was pretty similar across the United States as well. About 14% require hospitalization, 2% require ICU admission. And I think it's important to point out that among these numbers, a disproportionate percentage are actually Latinx and non-Hispanic Black, and this is likely related to underlying disparities in social determinants of health. Now, you asked the question of who do we see more often in the ICU, and the real two big risk factors are both age and comorbidities. The most common comorbidities that are driving the pathogenesis of this disease seem to be cardiovascular disease in about 32% of individuals, at least among the US population, followed closely by diabetes in 30%, and then chronic lung disease in about 18%. Now, importantly, hospitalizations were 6 times higher among patients with a reported underlying comorbidity, and deaths were about 12-fold higher in those with an underlying comorbidity compared to those without. So age is also a really important risk factor in this. The Chinese CDC reported that approximately 87% of patients were between the ages of 30 and 79. Again, highlighting a disproportionate burden of disease in people over the age of 30. Older age was also associated with increased mortality. Again, the Chinese CDC reported that case fatality rates were 8 and 15% among those between the ages of 70 to 79 and above 80, respectively. This was very similar to that seen in Italy and also the United States. In that 67% of cases were diagnosed in people over the age of 45, and 80% of deaths were reported in those over the age of 65. So age and underlying comorbidities really seem to drive the pathogenesis in this emerging disease.
So I think many of us have an idea of telling patients who's at risk and to take extra care. Now we are moving past 6 months into the COVID-19 pandemic, but we're beginning to see some demographic shifts, including increasing numbers of young patients being not only diagnosed, but in hospital.
It's interesting. It's a really, and this is a trend that I've just noticed over the past week, in that I'm actually seeing a demographic shift in terms of the patients that we're identifying from the outpatient perspective, and that we're starting to identify much younger individuals in their 20s to 30s. And I think this has to do with some of the reopening among states, certainly among the bars, and that we're seeing more younger people congregating in enclosed spaces without the infection prevention control measures. Within the hospitalized population, younger people are definitely being admitted, but typically they have an underlying comorbidity that I think is probably driving their disease severity.
So when patients ask me questions about how liberal they can be or how careful they need to be, I usually point to a couple things that I look at to give people some advice. Because if rates in the communities are falling, I think there's lesser concerns, although you still need to be careful for social distancing, and wearing masks cannot be emphasized enough. But I look at the WHO, which really has a goal of 1% of new cases should be less than 5% and hopefully declining. But of course, and then hospitalization, it's sort of like mortality and hospitalizations are very late indicators that there's a lot of problems in the communities. So there's been some discussion about RNA virus mutation. RNA viruses aren't generally as stable as DNA viruses. And a particular mutation has been in the news quite a bit recently, the D614G mutation. Early on, it looks when viruses had been recovered from patients in January and February, this was not a common mutation, but in recent months, it seems to be the predominant virus seen here in North America and also in some other countries. Based on animal models and also some sense that the efficiency of the virus of binding to its receptor, the ACE2 receptor, might be enhanced. People are wondering if this means the virus is mutating so it's a little less virulent, or that it might be more effectively transmitted in terms of asymptomatic spread. Because we don't have terribly effective treatments for COVID-19, and we're awaiting a vaccine, there have been significant debates about best practices for avoiding the transmission of this novel coronavirus. In fact, I think early on there were a fair amount of mixed messages for a variety of factors. And I know, Ed, this has really been at the heart of what you've been dealing with, not only for healthcare workers, but also just from a public health perspective. I know there's a lot of water under the bridge at this point, but from your view, looking at the data and practices, what are some of the key points that you like to tell people about trying to avoid getting infected?
Well, it's really a matter of what's the best PPE to use, both in the healthcare setting, out in the public. And to decide what type of PPE, you have to say, well, how's the disease transmitted? Is it airborne? Small particles, less than 5 microns, travel great distances and can stay aloft in air currents for long periods of time? Or is it droplet greater than 5 micron, 3 to 6 feet, falls to the ground? So generally, we think that the evidence points mostly to droplet transmission, that these particles don't go very far, but there's enough evidence to suggest that there's at least a small airborne component. Now, surgical masks are really designed to protect others from you. We do know that the COVID virus does get through surgical masks, but not as readily and won't travel as far likely if you didn't have a mask on at all. So if everybody paid attention to the disease and respected it and understood that there's a lot of asymptomatic carriers and pre-symptomatic carriers that can transmit disease, kind of assume that just about everybody can be a carrier and a transmitter, and then just have a little more respect for wearing PPE, surgical masks at least, or the cloth masks available to the public, and the social distancing of keeping at least 6 feet whenever possible, can go a long way towards trying to reduce transmission out in the community. Now in the hospital, that's a little different. We try to block transmission, whether it's mostly droplet or a small airborne component. And in emergency management, we always say, prepare for the worst and hope for the best. So we just operate in emergency management as if there's an airborne component to this. So that being said, when we go into a room where it's a person under investigation, a PUI, or a COVID positive patient, the PPE that we wear for those is an N95 mask and a face shield. If you go into a room that's tested negative and is not exhibiting any signs or symptoms or risk factors for COVID, then the universal PPE for patient encounters is a surgical mask and a face shield with the option to wear an N95, since anybody can be COVID positive, even without any symptoms, as we talked a little bit about. And that's the last thing I want to mention are these KN95s that people ask me a lot of questions about. Are they effective masks? And I've done quantitative testing on these masks. So an N95 should have a quantitative fit protection factor of greater than 100. The surgical masks I've tested had fit protection factors of 2, and the KN95s were anywhere between 8 and 60. So they have ear loops, they're not straps behind the head. So they're better than surgical masks, but they're not as good as the NIOSH approved N95s that we're used to buying for the hospitals.
So Ed, you raise a lot of valuable points. Some other people bring up a lot of concerns about certain environments, people that might be in mass gatherings, singing. There have been the meat packing plants. What are some of the other factors that you think might be important or as being a high risk environment for people acquiring disease?
Yeah, I mean, social gatherings, especially indoors, are very high risk. Again, we should just assume that everybody, even completely asymptomatic individuals, are positive or could be positive and could transmit this disease. And it's been shown that asymptomatic and pre-symptomatic, the days before you get sick, are times where you can have high viral load and transmit the disease.
As we're learning more about the proclivities of this virus and how it's transmitted, I think in the fall and winter, we hope people are returning to their customary workplaces, schools, needing to move from your home to workplace, perhaps by mass transit. Many of these require movement in areas that may not have great circulation. For example, elevators, mass transit, indoors where circulation may not be as optimal, all of which could conspire to increase transmission rates if we don't take great care in social distancing and wearing masks. I think there's a lot that we have to sort of keep in mind moving ahead. I'll just have to say I was always impressed because there was so much concerns and back and forth advice, where the CDC was more conservative about making airborne precautions with healthcare workers early on, and the WHO was sort of keeping to the droplet. And as we learn more and more, I think we look back that the droplet precautions, which work pretty well for SARS and MERS, really just don't seem to be the case with this particular virus. This is a respiratory virus. It's typical flu-like symptoms and so on. But Ed, when you've heard about cases and coming through the emergency room, have you had any particular issues or things that you like to keep an ear for beyond the typical influenza symptoms of cough and fever?
Yeah, so early on, we, like many other EDs, set up triage outside of the emergency department. We set up a 10, we did triage, and we asked a lot of the typical questions about respiratory illness and influenza-like illness. But it was clear even early on that we were seeing other things, the GI symptoms, the taste and smell issues, that the loss of those became more prominent. And we were seeing things that really made us respect this disease even more, like you had talked about earlier. We're learning as we go. We would get trauma cases that we would admit through trauma, and the next day they had ground glass opacities on their x-rays and had just fulminant COVID, and they weren't even suspected at all of being a COVID patient. It was a trauma case. And so we've learned, maybe the hard way, to really have respect for this disease. And although we try to triage it so that people that are high risk or had exposure, had typical symptoms, go to one section of the ED and other patients go to another, we wear PPE for every patient encounter, which at least surgical mask and face shields. And many of the staff are just wearing an N95 and a face shield for every patient encounter, just assuming they're COVID positive.
COVID-19, people seem to have GI symptoms. There's a lot of ACE2 receptors in the gut. Sometimes they're the first symptoms before people get ill. There's been ocular, conjunctivitis. There's been chilblains and, COVID toes, which got some popularity. The loss of taste and smell has been important. And Billy, this is your specialty here. And what's some of your takes on these hypoxic issues with this particular virus and clinical clues that can help guide care?
Yeah, it's unfortunately it's been really interesting to monitor this disease as it progresses and as we learn more. And I would say that there's three interesting findings that have really come from the ICU. Number one is that there's a quick evolving but silent hypoxemia. So a number of patients are actually having conversations on their phone with oxygen saturations below 90% in the 70s or 80s, and actually have to be intubated and put on mechanical ventilation, even though they're talking and they say they feel fine. And so that's been an unusual phenotype that we've seen among some critically ill individuals. Additionally, we're seeing a pretty high lung compliance. Traditional ARDS, the lungs get stiff with the exudates of protein and fluid from the vascular space into the lungs, and the lungs become pretty heavy and difficult and increase the work of breathing for the individual. With COVID, what we're finding is that the plateau pressures, which are a measurement of the lung compliance, are pretty low, indicating a pretty high compliant lungs or soft lungs. And this has been an unusual feature of this disease that's forced us to really think hard about what are the pathophysiologic mechanisms.
So Billy, thank you. The pathophysiology of this virus, we're going to learn a lot more about, and the presentations are different in different groups, but the diagnostics, I think we still struggle with. Initially, there were a lot of limitations obtaining the tests, but as we're using them more and more, I think we realize the limitations, both the molecular testing for viral RNA and also antibody tests. And Ed, I know in the emergency room, a lot of the early decision making was who gets the test, but now I think anyone with a concern for COVID-19 should be tested, but yet the tests aren't really picking up all the cases that we think when we're dealing with people under investigation. What have you seen sort of evolve, and where do you think we are right now in terms of how well these tests are performing?
Well, the sensitivity really isn't clearly defined, but we think it's somewhere for the PCR nasal swabs in the 70, 80, 90% maybe sensitivity at best. And that means at 20, 30% of people have false negatives. Now, when it's positive, that's positive. Generally, that tells you had the disease. So coupled with the fact that people can be completely asymptomatic or pre-symptomatic, and the sensitivity of the test really isn't in the 90s, it's lower than that. When you get a negative test, if you still have any clinical suspicion, we still treat them as if they're a COVID patient, and then tests are repeated after they're admitted.
Yeah, and we've had cases where people have fever, cough, ground glass infiltrates, and we're often stuck. We've done one or two tests and we're trying to figure out should they come off airborne precautions or not. And Billy, I'm sure you've seen patients like this in the ICU, and whether you or the infectious disease consultants or others, what do you do with these patients that look and smell like they have COVID, but the initial test or two are negative? What, do you just keep keep on? Do you have any other kind of tacks that you might take?
So traditionally, we go after the upper airway initially. That seems to be where we have the highest rates of replication early on in the illness. As that illness progresses, if somebody is in the middle of their illness and has an upper respiratory tract test that's negative, we'll tend to try to go for a lower respiratory tract. So sputum, if we can, tracheal aspirate if they're intubated, or bronchoalveolar lavage or BAL. And so again, I think it's important not just to think about the test modality, but also the location of that testing.
Yeah, and I think some of the other tricks sometimes are getting, especially if they're in the mid to later phases of infection, maybe during the hyperinflammatory phases, day 10 or later, serology might actually have a role there. We know serology, probably if you're looking as a screening tool or in a low prevalence population, may have cross reactivity. It may not be reflective, but if you're using the antibody test in someone that you think has COVID-19, you get high values of an IgA level, an IgM level, or IgG. I think then that sort of puts together a very consistent picture in that regard. But people that say, "Hey, I may have had a bad cold in February. Did I have COVID?" Then I think those are people which I've been very reluctant to get the test, because if it is positive, I don't know if it's a true positive. People may change their behavior because of it. So we've been pretty circumspect in what we think the current set of serology, because most of it's spike protein related antigen antibody testing. And until there's more sophisticated antibody tests with checking for a number of antibodies against the novel coronavirus, I don't think those like, did I have it questions can be answered by serology. But Ed or Billy, both of you, I think, certainly, initially there was this like 2 negative rule to take people off airborne precautions and so on. And people are doing a lot of retesting at times. We've had patients that have left the hospital, come back, they're retested, and they're positive at week 8 or even later after illness. Ed, how do you handle those people that seem to have had COVID in April, come back in June, and with some problems that maybe secondary infection or whatnot, but have a positive? How is your hospital system dealing with that?
You don't see that too often, where a person who had it recovers and then comes back with COVID-related illness. But when it does occur, we treat it as a possible recurrence of disease. Until more is known, we don't know how long the antibodies are protective for. We're not 100% sure that you can't get it again once you've had the disease in the first place. So they're still placed in the same type of precautions and still retested and presumed to be positive until we can rule that out.
Yeah, and Billy, I think there's certainly a lot of debate about people that are sort of re-positives or have this prolonged shedding. I think, as Ed said, we don't know for sure how long immunity may last, especially in people that may have mild disease or asymptomatic. Has your infection control team come out with any policies? I think we're all struggling with this, because a subset of people we think are not positive anymore in the sense of being infectious, but yet, people are just have these concerns.
So I like the word that you used, struggle, because I think we're all across the country and across the world struggling with what the meaning of these tests, what these tests mean, what the results of these tests mean, I should say. Because again, a positive PCR test just tells us that there's presence of genetic material. It doesn't tell us that there's infectious virus. So it's difficult to navigate some of these waters here. I think what we know so far, or I think that I should say there is evidence that virus replication may be dependent on severity of disease. More milder illness, they tend to have quicker viral replication. One study of mild disease showed about 90% were virus clear by about day 10. A second study of mild to moderate showed that the median duration of viral RNA detection was actually 24 days. So we're seeing this wide range. If you look at infectivity studies that have detected infectious virus, one study of mild disease of 9 patients out of Germany found that infectious virus wasn't able to be isolated beyond day 8. A more recent paper in more severe disease suggested that they could isolate infectious virus up to day 20. Again, maybe suggesting that severity of disease may be playing a role. Our infection control practices really follow viral RNA detection for the time being. And we follow, obviously, the updated CDC and WHO guidance.
I have to say, I've had some reassurance by the Korean CDC study that looked at so-called repositive. People were discharged from the hospital with a negative test. About 2 weeks later, on average, they were swabbed. A healthy percentage of those people were positive, and then they did contact tracing, trying to figure out if anyone was transmissible, and it didn't seem that that was the case. We talked a lot about diagnostics and now the care and support of patients. And so someone comes into the emergency room, mild illness, okay, you got some time. If someone's severely ill, what are some of the key points early on that you feel your clinicians tend to handle as they're making decisions?
As I talked about, we separated our emergency department into two areas, one for COVID, PUI, or high suspicion, and those for just the standard emergency department patients. And in that separate ED, we have areas that are designated for respiratory care. In those areas, the providers wear full respiratory protection, PAPRs, powered air purifying respirators, to give them complete protection in the event they need to do an aerosol generating procedure like an intubation. But like what both you and Billy said, we're kind of learning as we go. And we have seen SATs in the 80s for people that are very mildly symptomatic, and we don't intubate those early on. We try to avoid it, and we go with high flow oxygen the best we can. Different than what we see in other diseases. And then we have people whose SATs might be in the low 90s and would be considered moderate disease, but are in significant respiratory distress and have a lot of disease on their x-rays, requiring earlier intubation.
Yeah, Ed, the variability, I have to say, has just struck me tremendously. Billy, since February and March and some of the early reports from China and Europe, what are some of the tricks that you and your colleagues have been using with trying to either anticipate or employ with your critically ill patients?
I think we have a three-pronged approach, and it's all centered around good supportive care. In these outbreaks, there's often these ebbs and flows of data and suggestions and strategic interventions. I think if we continue to do the very basic things well, we will save lives. And some of that basic stuff is really good supportive care: oxygen therapy, fluid conservative therapy, following electrolytes, making sure that we do the basic things really well. This is primarily single organ disease. We're seeing some people who develop kidney failure that require renal replacement therapy, some patients that require shock, but the vast majority of patients really have single organ disease. And so we really try to improve their oxygenation as much as possible using the traditional tricks. Non-invasive ventilation, I'm actually finding better success with CPAP and BiPAP more so than high flow nasal cannula. I agree with Ed, we try not to intubate people if we don't have to. We use that as a last resort. But oftentimes our hand is forced in that setting. I will say there are two things that have really shown to be helpful. And the number one thing is proning. We have had remarkable success with proning. Now, proning has been demonstrated to have a mortality benefit in patients with ARDS from the PROSEVA study. But I will say that in this disease, I feel like proning has a disproportionate benefit in patients who are both intubated and non-intubated. So we are proning patients who have not yet been intubated, who may be on face mask, even patients who are on non-invasive ventilation with CPAP and BiPAP, and we're seeing an improvement in their oxygenation. So I think strategically that's a major focus. Now, in addition to that good supportive care, we're also trying to initiate early antiviral therapy. We'll talk about remdesivir in a minute, but so far remdesivir is the only drug that has demonstrated some benefit in this disease from an antiviral perspective. And then, of course, we've all seen the recent data from the recovery trial on dexamethasone. And so I think adding an immune modulator for patients with oxygen requirement and specifically severe disease, I think is important. It's important not to use dexamethasone in patients who don't have an oxygen requirement, as there is a trend to harm in that population. So again, really good supportive care, maximizing oxygenation and maximizing the lung protective strategy. So in ARDS, we use low tidal volume ventilation. combining that with early antiviral intervention plus immune modulator in the right patient population.
Yeah, Billy, I really think you emphasize the importance of the supportive care aspects. I mean, I think so often we're looking for the magic bullets, the quick fixes. It's the way of American medicine and way how we think. We got a problem, we got to fix it.
And Paul, I might add that what's really important to remember is that these interventions, these basic interventions like oxygen and IV fluids are not available everywhere. And there's incredible disparity in access to care. And that's something that I think that we really have to fix. I do think an outbreak anywhere is a threat to lives everywhere. And so I think we really have to do a better job of getting the right resources to the people who need them.
Yeah, no, I that's a huge topic and one that's, also true here in the United States, where there's often overwhelming amounts of work and capabilities for critical access hospitals, for example, and so on. And as we sort of look at patients, it'd be great if there's prevention aspects. Of course, we're looking for vaccines, but they're probably still a ways off. There may be temporary fixes with uh, monoclonal antibodies or convalescent plasma as a prevention. But for our ill patients, there have been a lot of different modalities that were tried early on with limited data. We're beginning to get some of the randomized controlled trial data. And probably the first one that was significant was remdesivir, which is an intravenous antiviral that's a prodrug. Initially was purposed for Ebola, lost in a contest against antibodies for treatment of that disease, but has been repurposed with some initial success in a primate model against the Middle East respiratory syndrome virus, and now has been trialed in a large study called ACT-1, which has had preliminary results published. And Billy, your colleagues and you, when you look at this trial, it was the first one out that really has had a big splash. Um, it's still an investigational drug. The FDA has released it under the Emergency Use Act. What's your sort of view on this? I mean, I know you're looking at the more severe patients, but are you using it in the ICU? I mean, when should we be using the drug based on the data?
So I think the remdesivir. So first of all, I think it was. I think it's a really important study, not only because it has shown a benefit in terms of reducing the duration of illness associated with COVID, but because these investigators were able to do a really well done, ethically designed, randomized controlled trial in the middle of a pandemic. Now, the study showed that it decreased the duration of illness from about 15 days to 11 days. So that's a significant finding because we'd all argue that we would like to be sick less long than longer. And so right now it's currently being used in patients who have some severity, who have severe illness. And so these are patients who have oxygen requirement, evidence of lower respiratory tract disease, but especially but patients who are less than 10 days on mechanical ventilation or ECMO. And so our hope is that the earlier we can use it, the better. Now the study, the mean time from symptom onset to initiation of therapy was about 10 days. So we'd like to try to start that as early as possible to decrease virus replication and potentially improve outcomes. But I think this represents the beginning of the beginning. And I think we have to keep going. We have to keep using science to guide therapy.
Yeah, Billy, I agree. It's always so hard to do studies. And of course, many areas that were set up to do it have falling numbers, just like they did in Wuhan, to try to understand this. I think a lot about influenza, where we have drugs that aren't that great, right? We have the neuraminidase inhibitors like oseltamivir, and the earlier you take it, the more potential for benefit. Yet we have a drug like remdesivir, which we don't have unlimited quantities of. We want to try to target it to the patients that are going to benefit. But as an antiviral, it just seems to me this would be better used earlier, but it's not the easiest drug to manufacture. And there are some other studies in progress, but it has become as it were, the standard of care now, I believe, for antiviral aspects of therapy. The other drug which you mentioned was the dexamethasone. So I think many of my critical care colleagues at Johns Hopkins were quite shocked at the recovery trial. I mean, this was the first RCT in COVID-19 that had a mortality benefit, and I think a lot of it was colored because ARDS and steroid studies have really been checkered in the past. But this disease is really a monomorphic disease. It's, you have lots of people with hyperinflammation and lung injury. And I know we only have preliminary results from this trial again, and it's in preprint, not even in peer review. There was some reluctant embracing, but most have come around to think that we have to think about this.
So I think this is another example of a really well done trial in the middle of very difficult circumstances. We were surprised as well, but it was a good surprise. We were surprised mainly because observational studies from influenza suggested that that steroid use was associated with increased mortality related to secondary bacterial and fungal infections, as well as prolonged viral replication. So to see a mortality benefit, and the size of this mortality benefit was quite striking. Based on what we've seen from their data, we are using dexamethasone the way that they've used it in patients who have severe disease manifested by an oxygen requirement. Now, we are not using steroids. In fact, they really stress this in their discussion, that steroids in patients without oxygen requirement actually trended towards potential harm. And so we're reserving the use of steroids to patients who have oxygen requirement, especially those who are on mechanical ventilations or ECMO. But again, I think this is the kind of research that we need in a pandemic to guide us down a path amidst incredible uncertainty.
It took a little while to let it sink in and to analyze it. Any reservations, just because the mortality rate was far higher in the UK than what we see here, and maybe the ventilated patients were younger, for example, compared to the other cohort, and maybe it doesn't exactly reflect all the practices that we have here. Maybe that significant mortality benefit, especially the mechanically ventilated patients, may not be quite what we'll see here. And then lastly, just for a comment, some have brought up, of course, giving the immunosuppressive, where are you going to see problems after 28 days?
So I think your points are really well taken. The age was interesting, the age difference. But I think it also relates more to how mechanical ventilation is offered in the UK. And that sometimes mechanical ventilation isn't offered to older individuals. And so there may be some different practices that explain those findings. But reservations, I mean, always. I think we've learned never to hang your hat on a single study, but this one was particularly well done, was really large. And so I think we're following its guidance now.
So thankfully, so many of our patients that are infected with the novel coronavirus don't have severe disease and don't end up in emergency rooms or the intensive care unit. But yet, I think there's a lot of confusion and perhaps lack of good guidance for patients in home environments, and a lot of challenges there too.
Now, there are other studies looking at steroids, and this is going to be really important to see how those trials play out. So there's REMAP-CAP, which is a multi-center study that's looking at a number of different interventions as well. And so I'm going to be excited to see their data to see if their findings were similar to the UK group.
Ed, what are some of the ways that you're advising people and some of the key points you like to drive home?
So we've really, like other centers, I've really put a big emphasis on our telehealth program. And we have gotten thousands of calls from telehealth for people that are concerned about their COVID symptoms. And trying to develop an algorithm for outpatient management has been challenging, like so many other things related to this disease. And another thing that comes into play in trying to decide what to do people as an outpatient is what their home setting is like. And we look at that all the time normally, but it's even more emphasized with COVID. So can they stay isolated or quarantined? Do they have people that can take care of them at home? If they have to be transported to the outpatient setting, how are they going to get there? Public transportation is risky. They're going to be in a car with someone that's a very closed environment. And then are they at home with somebody that has comorbid conditions, elderly that would be at higher risk if they stayed home and didn't get admitted to the hospital? And then you also have to factor in how many beds do you have, which really we try not to make that a deciding factor, but resource utilization does come into play in a pandemic. And like it or not, that plays a role in our decision making. So there's no real clear algorithm that you can just go different branches and say, okay, they should come to the outpatient setting or to the emergency department. But generally what we've been doing is if they have dyspnea or shortness of breath with more than just significant effort, we recommend that they get at least evaluated. Or if they have significant comorbid conditions or other things that are concerning like confusion or falls or something of that nature, very mild symptoms or just exposures, we do our best to have them stay home, to be isolated if they have symptoms, quarantined if it's an exposure, and then frequent follow-ups by telehealth. So if it's shortness of breath, I know we've all seen people that weren't bad for a day or so and then suddenly get much worse over the next day or so as well. So if it's shortness of breath, we try to follow them up within 24 hours. If they're not having significant symptoms, maybe a few days later, we'll do a follow-up. And unfortunately, as much as we search for just a single algorithm that makes a decision for us if we follow that pathway, this disease has really not lent itself well to that kind of approach.
Yeah, Ed, a lot of the questions that I think are people want to know is how long do they need to stay isolated? What happens if they get checked just a couple of days after exposure in the household? Are they in the clear? What are some of the frequent questions that you think you and your colleagues often get asked in these kind of situations?
Yeah, no, that's a great question. And we're generally going along the guidelines that if they've been exposed to somebody, a test itself can't completely rule out that you're not incubating the disease. And we talked about the sensitivity maybe being 70%. And it depends when you do the swab. The sensitivity changes as the disease progresses. So we've been telling people generally 14 days, knowing that there are some studies. Billy at least mentioned one that was talked about 24 days out that you could incubate this. But generally, we tell people to quarantine for 14 days if they've been exposed. And we don't use a negative test as a rule out that they're completely out of the clear. And we don't even really recommend that they get tested if they've been exposed in a high-risk setting, that they just quarantine for 14 days.
Yeah, thank you, Ed. I think these questions come up more and more because they're sort of contrary to a lot of the relaxation aspects and so on. And I think everyone's sort of hopeful that cases will be down, that there'll be a vaccine. My own view is a lot of these, what I would call first generation vaccines, if they do prove to be safe and perhaps have efficacy, may not be quite as effective as perhaps later developed vaccines as we learn more about the virology and the immunology, may be more akin to influenza, where it offers some partial protection or attenuation of disease. So I mean, I think looking forward at this, especially from the emergency room, what are some of the challenges that you view with the upcoming, respiratory season, traditionally with influenza? And I think it looks like we're going to have COVID to deal with for sure during that time.
Yeah, we really don't know where this is going, whether this disease will, burn itself out quickly or whether it will progress and whether we'll have a second wave. But again, with that emergency management mantra of preparing for the worst and hoping for the best, we're just assuming that this second wave is going to come and it's going to be more severe than the first. That happened in 1918, that the second wave was more serious. And that's going to occur at the same time we're seeing influenza A and B and RSV and seasonal coronavirus all at the same time. So we're really already starting to ramp up our capabilities to test for all of those diseases, figuring it's going to be important to try to sort things out when people come in with respiratory illnesses this fall. We're assuming that all of these diseases are going to occur at the same time, and that we really would recommend that everybody kind of ramp up for that possibility and be prepared to do increased testing for all the common viruses that occur in the fall and winter months, along with COVID testing.
Yeah, I think the days of whether we can make a clinical diagnosis of influenza in an urgent care emergency room setting are over. as long as we have circulating COVID. Now, Billy, I wanted to ask a question that I was wondering if you and your colleagues are pondering. How is your institution beginning to think of this in terms of allocating resources? I'll just mention Hopkins, where we're, we're trying to see if we can ramp up ICUs, for example, if needed again, and not shut down elective surgeries, for example, that might require ICUs.
So I have a couple thoughts. The first one is that we can't have a second wave until we're done with the first wave. And in fact, in the Southeast, we're still seeing increasing numbers of infections, hospitalizations, and deaths due to COVID. So we're still in the thick of things. And I think that's a key piece. And with that, I think this is a predictable response to reopening of states without continuation of infection control practices that we know work. We know how to prevent transmission of this disease. It's masking, it's hand hygiene, and it's physical distancing. If we do those three basic things well, we can prevent transmission of disease. From a resource utilization standpoint, Ed's fears are my fears exactly. Our biggest concern is that with the increased rates of influenza that we typically see in the fall, combined with COVID-19, that we're going to overwhelm the healthcare infrastructure, and we're going to prevent not only really good care of patients with severe illness due to COVID, but also the essential health services delivery. So pregnant women still have to be delivered, emergency surgeries still have to be conducted. And so we have to be able to manage both of those things, the management of COVID-19, but also these essential healthcare services. And so I think that's the biggest fear. And that's why these infection control practices, which are cheap, easy, and we all know how to do, are so important to implement now to prevent that transmission.
And I know Ed and Billy, you probably have some situations that stick out in your mind that's just important to pass on to either patients or clinicians. Maybe Billy, you might have some first.
So I think I have two thoughts. And my first thought is do the basic things well. And this is something that applies both to infection control as well as to treatment. If we do the basic things well, we can stop community transmission. If we do the basic things well, we can provide really highly effective supportive care that gives patients who are severely and critically ill the best chance of survival. And I like to think about this from the sense that even the most effective therapeutic won't work if we don't keep somebody alive long enough to receive it. And so supportive care, I think, is the foundation of care for patients with severe viral diseases. The second point is that I think we have to learn in real time. And this takes a community working together to advance the understanding of the disease and the implications for both infection control as well as therapeutics by working together. We are entering into a truly new era of antivirals that are effective against respiratory viruses. And as we walk down this pathway, I think it's critical that we use well-designed, ethically designed randomized control trials to really drive the science behind this disease so that we can apply what we learn to how we take care of patients.
And then Ed.
Yeah, thanks. I also have 2 points I wanted to make. And one is maybe the most common question I get asked is, where is this disease going? What's the future look like? And I have to smile when the question's asked. And I try to look back historically. What have we learned from events in the past that might help us decide? And then when you do that, it's even more confusing. So here's 3 different diseases. 2 of them are coronaviruses, completely different. So is this going to have a second wave worse than the first? Is it going to just burn itself out like SARS? Is it going to continue to be part of our disease history every year like MERS? Well, we'll know it when we see it is really the answer. We don't know. And then the second point is just what you both have mentioned, is the curves we keep seeing with the disease, and that we learn on the fly. And it's really just to have a healthy respect for this disease. And the current data is that maybe 35% of people are asymptomatic. Higher than that, maybe 80% of people under age 20. And if those numbers are even close to being accurate, and they change all the time, and they may get even higher, then the best way, I think, in at least the immediate future, is to do what you both have mentioned, and that's just common sense, social distancing, 6 feet, wash your hands, wear a mask. And if you do those simple things, I think we can really mitigate the chance of this becoming just even worse than we are currently seeing it. So respect this disease. It may seem mild at times and it's going away, but but we really don't know what's going to happen to it. We've seen so many different paths in previous diseases that just have a healthy respect. Until there is a definitive vaccine, just use social distancing, hand washing, masks, and we'll all get through this.
I am optimistic. In the face of terrible losses and tragedy, I think some less than optimal coordination globally. I do think we have amazing resources. We've faced significant challenges in the past with polio, finally finding a successful vaccine, HIV, the pharmaceutical industry really coming up with amazing antivirals there to control disease. So as both you and Ed and Billy have mentioned, I think there are resources that will be developed. It may take some time, but there'll be both therapeutics and prevention aspects. But until then, we really have to count on social distancing and mask wear. I also think it's important to keep an eye on some of the guidelines that are coming out of the NIH and the Infectious Disease Society of America that can try to help synthesize some of the information for best practices, which are certainly to change on almost a weekly basis as new data comes out. And lastly, your local health department, state health agencies, and also the Centers for Disease Control, along with the WHO also can help even with some of the confusing back and forth. I think there's still the goal to try to do what's best. I'd like to thank both of our expert faculty, Dr. William Fisher and Dr. Edward Jasper, for their tremendous insights and discussion. And I'd like to thank you, our audience, for participating in this clinical dialogue. To receive your CME credit, click on the post-test button located beneath the slide in this video player. I'm Paul Auerter, and on behalf of Billy and Ed, we hope you've enjoyed this program. Thanks for joining us. This program will receive ongoing updates when critical information is incorporated so that you may have the best available information and evidence for caring for your patients.